Welcome to this second session of the lecture series on the topographic anatomy of the head and neck region. In this particular session, we are going to look at the anatomy of the parotid region and the anatomy of the facial nerve. So for that one, the parotid region, we are specifically looking at the anatomy of the parotid gland. So I'll give you two lecture outlines, one concerning parotid region, which we are going to start with, and the other one concerning facial nerve. So in the first part, where we're going to look at the parotid region, this is going to be our agenda. First, we look at the parts and gross anatomical morphology of the parotid gland. Then we look at how the fascia that surrounds the parotid gland is organized. We can call it parotid fascia or parotid capsule. We'll also look at the relational anatomy of the parotid gland. And while we are here, we are going to look at the things surrounding it, as well as the structures within it. They're still part of relations. And then we look at the histological structure of the parotid gland itself. How does it look like under light microscopy? We'll also talk about the anatomy of the parotid duct. We will talk about the blood supply, which means arterial and venous, as well as lymphatic drainage of the parotid gland. And we'll also talk about the innervation of the gland. That will be the last agenda for this particular part. Let's begin with the gross morphology of the parotid gland. So basically, we may have a main gland and an accessory gland. The main gland lies largely in front and inferior to the opening of the ear, the external auditory meatus. So this is the gland. This is where we expect the external auditory meatus. So this is the gland. It is anterior as well as inferior to the external auditory meatus. We can see that it lies between two major muscles, sternocleidomastoid posteriorly, and masseter, which has the mandible anteriorly. So the mandible is the bone, and masseter is the one that's covering that bone there. The gland projects onto the anterior surface of the masseter, as I've already mentioned. The accessory gland, on the other hand, usually lies between the zygomatic arc, which passes above, and the duct of the parotid, which passes below it, so somewhere there. And this accessory parotid gland is a variant one. It is not necessarily present in everyone. Perhaps just a fifth of the population has the accessory parotid gland. Having said so, let's talk about the gross morphology of the parotid gland. It is the largest salivary gland, weighing about 25 grams. You know that we also have other major salivary glands. So we have the sublingual and the submandibular glands. Those are the major salivary glands, but now parotid is the largest of the three. It appears triangular when you look at it from the lateral view, as you can see here. Perhaps this is the base and this is the apex. But this gland generally has a superficial part and a deep part. The superficial part is what we are able to see easily here. The deep part, as the name suggests, is much deeper. And the plane of the two correspond with some structures. So there's some landmarks that can be considered to be the one dividing the superficial and the deep parts of the gland. In particular, we can look at the ramus of the mandible as one of the markers of separation of superficial and deep, but we can also look at other things. For example, we can also look at the neurovascular plane or the neurovenous plane. The neurovenous plane is this plane consisting of the facial nerve and the retromandibular vein So the retromandibular vein and the facial nerve constitute the neurovenous plane, which divides the gland into a larger superficial part and a smaller deep part. This region corresponds with the ramus of the mandible. As you can see here, so this is the mandible. So we can talk about this to be the mandibular ramus. And you can see the nerve and the vein fall along that plane, separating the superficial from the deep part. The junction between the two is what we call the isthmus of the parotid gland. In general, the gland is irregular and lobulated. And if you look at it in terms of that triangle, it's actually an inverted pyramid. That means that the apex of the gland is basically inferior. This is the apex, and so the base will be somewhere above. This apex overhangs on some muscles, for example, the posterior belly, the gastric there, as well as the sternocleidomastoid. Having mentioned that it's an inverted pyramid, we'll expect then that it has four surfaces. The superior surface is otherwise the base. Then we have the superficial surface, which you are seeing here. And then there are two medial surfaces. There's an anteromedial surface and a posteromedial surface. So those are the surfaces of the parotid gland. And with that gross morphology, we can now talk about the capsule or the fascia that covers the parotid gland. So traditionally or historically, the parotid fascia or the parotid capsule has been considered to be just an extension of the deep fascia of the neck. The deep fascia of the neck is termed the investing fascia. So its superior extension is what has been considered to be part of the parotid capsule. And historically, it's been described as just a split of the investing fascia into two. So there's one layer that passes superficial, we call the superficial layer of the parotid capsule. And we have a layer that passes deep, we call that the deep layer of the parotid fascia or capsule. The superficial layer specifically attaches superior to the zygomatic arc. Generally, it will also attach to the external acoustic meatus and mustard processes. We note that this particular fascia blends with the platysma. And so there's a newer view of looking at this fascia because it blends with the platysma and indeed may even have some muscular fibers within it as extensions of the platysma. It is now viewed that the superficial layer of the parotid fascia is actually part of the superficial musculo-aponeurotic system of the face. You remember the isthmus in the previous lecture, we described that layer, the superficial musculo-aponeurotic layer of the face. So we consider that this superficial layer is an extension of that one because they blend together. Perhaps this can remind you of that concept. So that light one is the one that we are following. So it's the one with the platysma, and we can see that it actually continues there as part of the superficial musculoaponeurotic system of the face. Now, deep to that, we can see that there is still the investing fascia there with a layer still in front, which is now part of the parotid masseteric fascia, and that is definitely part of the deep fascia. And we also have now the deep layer of the parotid fascia there. So the superficial layer varies in thickness. There's a thick fibrous layer anteriorly and a thin membranous layer posteriorly. It varies in thickness. So when you look at it this way, we can therefore say that anteriorly, the parotid capsule or the parotid fascia has two components. There's that component which is actually part of the extension or part of the isthmus layer. And then there's the part which is actually the true fascia, considered to be the split of the investing fascia. So the two of them are still in front and they're blended together. Now we have the deep layer, definitely. The deep layer of the parotid fascia attaches to the mandible. It also attaches to the styloid process. It attaches to the mastoid process as well as the tympanic plate, which you can see here. So here we have the tympanic plate and the styloid, but attaches to multiple bones. Remember, it's deep. This image shows you that anatomy very well. So this is the deep layer of the parotid fascia. It is the true fascia, and it's definitely the one that covers the muscles. It contains some ligaments within it. Two important ligaments, the stylomandibular ligament and the mandibulostylohyoid ligament. The stylomandibular ligament is considered a true ligament. However, the mandibulostylohyoid ligament is considered just part of the thickening of the deep layer. Of note is that these ligaments separate the parotid gland from the submandibular gland. So the submandibular gland will be much in front and the parotid will be posterior. The ligament, or we can say that the deep layer separates the parotid from the submandibular gland. That is the anatomy of the parotid capsule. We can now talk about the relation anatomy of the parotid gland. In terms of relations, we can talk about relations of different parts. We can start with the relations of the apex. So the apex of the gland is this one. Posteriorly, we see that, or rather deep to that region, we see the posterior belly of the gastric muscle there. We also see that sometimes the apex may be too long and overhang over the carotid triangle of the neck. Now we are yet to learn what is the carotid triangle, but generally the neck has multiple triangles. We have anterior triangles and posterior triangles. The anterior triangles are multiple, one of them being the carotid triangle, which contain the carotid sheath, among other structures. We look at them later. So the apex of the parotid gland may overhang on the carotid triangle, as you can see in this particular image. How about the relations of the superior surface? So the superior surface is not what we're seeing. This is superficial. The superior surface is basically the base, which is up. The superior surface is related to the external acoustic meatus, which you can see there. So that's the external acoustic meatus. So basically the base of this gland is related to the external acoustic meatus. It is also related to the posterior aspect of the temporomandibular joint. Remember, the mandible ramus comes somewhere here. And so we expect the temporomandibular joint to be somewhere there. So we have some deep substance there, which forms the base of this particular gland. And that base is related to the posterior aspect of the TMJ, temporomandibular joint. Okay, this shows you the temporomandibular joint actually. So the part of the gland that is somewhere here is part of the base. We also have the auriculotemporal nerve, which is a branch of the posterior division of the mandibular nerve. It pierces the base and it's also a relation of the base. So it goes through the base. So this is the auriculotemporal nerve after it has pierced and also related closely to the base of the gland. It's now coming out. It applies the skin over this region, if you remember that from the anatomy of the scalp and face. How about relations of the superficial surface. So the superficial surface, the surface facing us here, the superficial surface is covered by skin and superficial fascia. That superficial fascia contains a number of things. So we can consider it can contain the muscle fibers of platysma, which continue into it, as you can see in that region. We also have the facial branches of the greater auricular nerve. So the greater auricular nerve supplies this region. So the facial or the anterior branch of the greater auricular nerve are branches that are over the superficial surface. As you can see here, that's the greater auricular nerve. So we have the facial branches there. And of course, we expect some superficial lymph nodes there. We can call them preauricular nodes. They're usually just anterior there. So this image captures that, perhaps with this being the glandular coronal image. So this is the deep part, this is the superficial part. And so on the outer zone, we have the skin, we have superficial fascia, we have extensions of platysma there. And of course, we may have lymph nodes also within that particular region. We can now talk about the relations of the anteromedial surface. So remember the medial parts, we have anteromedial and anterolateral. Sorry, anteromedial and posteromedial surfaces. Those are the medial surfaces, anteromedial and posteromedial surfaces. Starting with the anteromedial relations, we have the posterior inferior aspect of the masseter muscle being an anteromedial relation. So if this is the gland, this is the masseter, the posterior and inferior aspects of this muscle is on the anteromedial surface of the parotid gland. Maybe this is a better image. You can see the muscle is deep there, and this is the gland. So the muscle is anteromedial. We also have the posterior border of the mandibular ramus. You will imagine that we have the mandible here. So the mandibular ramus is also there. And we also have the lateral aspect of the temporal mandibular joints up here, the lateral aspect of the TMJ and the adjoining mandibular ramus. So this one shows you the parotid gland. This one shows you the masseter there. And we'll expect the temporal mandibular joint to be somewhere there with the lateral aspect of the mandibular ramus there. We also have the emerging terminal branches of the facial nerve. So this branch of facial nerve arise slightly medial to the anterior margin, which means therefore that they emerge through the anteromedial surface of the gland. This other image also shows us those branches of facial nerve, but we'll talk more about them when you look at the facial nerve anatomy itself. So this image is a summary of the anteromedial relations. We can see that we have the masseter there. We also have the posterior ramus. Sorry, yes, the posterior mandibular ramus. And the medial pterygoid muscle is also there as an anteromedial relation, because this is the anteromedial surface. And you can see the branch of facial nerve coming out slightly medial to the anterior margin. So they're also anteromedial relations. This is the border between anteromedial and posteromedial relations. So as we've seen, the medial pterygoid muscle is also a relation of that region. This other image also captures what we've just mentioned: masseter, the ramus of mandible, medial pterygoid muscle. These ones are on the anteromedial aspect, the branch, emerging branch of facial nerve there. Now we can talk about the posteromedial relations. We can classify the posterior relations according to what type of tissues they are. The osseous structures, which mean the bony structures, we have the mastoid process, which is somewhere there, and the styloid process, which is somewhere there. In terms of the muscles, we have the posterior belly of digastric muscle. We also have the sternocleidomastoid muscle there. We can also talk about blood vessels. We'll talk, in this case, the internal jugular vein, the external carotid artery, and the internal carotid artery. So the external carotid artery basically is a relation of the posterior medial surface before it pierces the gland. But the internal carotid artery, you can add the term carotid here, the internal carotid artery together with the internal jugular vein are actual posterior medial relations. The external carotid will be initially a posterior medial relation before it pierces the gland. So this image tries to show us the posterior medial relations. So we've talked about two bony structures, the mastoid process and the styloid process. We've also talked about two muscular structures, the sternocleidomastoid muscle and the posterior belly of digastric muscle. I want to add the other musculature, which are still posteromedial. These are the muscles around the hyoid. So we call them the muscles around the styloid process. So we call them styloid apparatus. We have three muscles here: stylohyoid, styloglossus, and stylopharyngeus muscle. There are muscles attached to the styloid process going down to the various structures. So they are also posterior medial relations of the thyroid, of the parotid gland. We have some cranial nerves which are also related to the parotid gland. These glands, so these nerves are the cranial nerve number 9, number 10, number 11, and 12. Remember, number 9 is called the glossopharyngeal nerve. Number 10 is the vagus nerve. Number 11 is the accessory nerve, and number 12, the hypoglossal nerve. In particular, the 10th nerve is within the carotid sheath, in between the internal carotid artery and the internal jugular vein. There are also some visceral structures which could be still related to the parotid gland, especially when the deep part of the parotid gland extends much deeper. It will be almost abutting the lateral pharyngeal wall. This will be in particular at the junction between the anteromedial wall and the posteromedial wall. At that junction between the anteromedial wall and the posteromedial wall, that region may be related to the lateral pharyngeal wall. And so remember, that's basically part of the deep part of the parotid gland. So those are the relations of the parotid gland. We commonly term the posteromedial and anteromedial relations as structures within the parotid bed. So when you talk about structure in the parotid bed, we'll be talking about both the anteromedial relations as well as the posteromedial relations. And I believe you've captured them well. So just to understand that term. As we talk about relation the thyroid of the parotid, as we talk about relation the parotid gland, it is important to remember that other than the structures which surround the parotid gland, we also have structures which go through the parotid gland. And in particular, I can group them into three entities. One, we have the external carotid artery and its branches. The external carotid artery, as I've mentioned to you earlier, enters the parotid gland through its posteromedial surface. So it is initially a posteromedial relation, then a structure within the gland. This is the external carotid artery. It's a branch of the common carotid artery. It passes through the gland. It has many branches. Some of these branches are not necessarily inside the gland, but there's some branches that are inside the gland. So this shows you the external carotid artery as well, given off from lower neck, the one that supplies most of the structures of the external face and skull. Then internal carotid supply the brain. We can consider branches of the external carotid as anterior branches, posterior branches, medial branches, and terminal branches. Not all of them are within the parotid though. Posterior branches are just mainly two. We have the posterior auricular artery, and we also have the occipital artery. The occipital artery is not within the gland. The posterior auricular artery may be given inside the gland. The anterior branches of external carotid are basically the superior thyroid artery, the lingual artery, and the facial artery, and all those are not inside the parotid gland. So coming up here, we can see that the external carotid divides into two. We have the maxillary artery and the superficial temporal artery. And those two are the terminal branches of the external carotid artery. Those two are found within the gland. Actually, the division occurs within the gland. As I've already mentioned to you, the posterior auricular artery may pass through the gland sometimes. It's not always. Now, don't forget that the maxillary artery and the superficial temporal artery also have branches. And some of these branches are also still within the gland. For example, we have the transverse facial artery, which is a branch of the superficial temporal artery, this one. And we can see that that one usually also is found within the gland. Some branches of the maxillary artery may also be given within the gland. Okay, so that is with regard to the artery. Then the second entity is the retromandibular vein and its tributaries. The retromandibular vein is a vein that drains the scalp. We know that's formed by the union of the maxillary vein and superficial temporal vein. That union occurs actually within the parotid gland, which means that the superficial temporal vein, which accompanies the superficial temporal artery, is also found within the gland, and the maxillary veins are also found within the gland. Remember that when the two veins meet, they form the retromandibular vein within the gland, which you call number one there. The retromandibular vein then usually divides into two. Before that division, it runs superficial to the external carotid artery. So when you come from the surface, you'll find the vein first before you get the artery. It divides into two. We have the anterior division and the posterior division. The posterior division of the retromandibular vein joins the posterior auricular vein, and the two form the external jugular vein. So you may not necessarily have the posterior auricular vein inside the gland, but definitely the posterior division of retromandibular vein may be found within the gland, and the two join to form external jugular vein. Now, external jugular vein is not found, is not formed inside the gland per se. The anterior division of the retromandibular vein also joins with the facial vein to form what we call the common facial vein. And this common facial vein drains into the internal jugular vein. So again, the anterior division of retromandibular is found in the gland, but the facial vein is not necessarily found in the gland. And definitely, the common facial vein is not found within the gland. All right. Then we have now the facial nerve and its branches as the third entity of structures found within the parotid gland. So facial nerve enters the parotid gland and divides into it, but we're going to talk more about that when we look into details of facial nerve. This image just captures for you that nerve which divides multiple times in the gland. And as I already mentioned to you earlier, it may be used as a landmark to separate the superficial and the deep lobes of the parotid gland. Well, the last thing maybe to mention is that we also have lymphatic vessels and lymph nodes definitely within the gland. The lymph nodes within the gland are the ones we term the parotid lymph nodes. So that is about relation anatomy. We can now talk about the histological structure of the parotid gland. So this will focus largely on the light microscopic features of the parotid gland. Let's begin by talking about some general organization. So in general, the parotid gland, just like any other salivary gland, will be basically an exocrine gland with both stromal and parenchymal tissue components. So this is general for any major salivary gland. We'll have those two components, the stromal tissue and the parenchymal tissue. When you talk of the stromal tissue, we are largely referring to the connective tissue elements that offer a supportive framework to the gland. So this particular framework consists of the parotid capsule, which means the connective tissue that was surrounding the gland. But it's not limited to the fascia, it's not limited to the capsule. It also entails or involves the trabecular system within the gland. Now, the trabeculae are basically the connective tissue that splits the gland into multiple lobes or lobules. So we have some connective tissue that extend from the capsule into the gland, dividing the gland into lobules. Those are still part of the stromal tissue. In particular, the stromal tissue houses a number of structures. The nerves run there, the arteries may run there, as well as lymphatics, and even the large duct, what we call the excretory ducts, they run within the connective tissue element. So they are still important in terms of offering support to the gland as well as the other structures which pass in the gland. So that's the stromal tissue, the connective tissue elements. Then you have the parenchymal tissue components. The parenchymal tissue components refer to the secretory acini of the gland as well as the ductal system. And there's something called the Salivon that we're going to describe shortly. Let's begin with the stromal tissue elements of the parotid gland. So the stromal tissue consists of a capsule, as you can see this layer there. The capsule is a connective tissue, it's fibrous connective tissue. As we can see there, of variable thickness. Here we can see not as thick, but of course here we can see it's very thick. So it's of variable thickness. This fibrous capsule, as you can see, sends in some septae like that one, and that one. And that these septae tend to divide the gland now into lobules. Like this is one lobule, that's another lobule, that's another lobule, that's yet another lobule. The capsule sends in septa that divide the gland into lobules. Important to note is that the septa that goes into the gland carry blood vessels, as you can see that one, or even this one. These are blood vessels. Not just the blood vessels only, we also have the ducts, which are found within that connect tissue trabecula inside the gland. Like that's a ductal system. This image captures for you the trabecular system as it enters into the gland to divide it into lobules. Also demonstrates how the trabecular system houses the ductal system and blood vessels. Now we can describe the parenchymal tissue. The parenchymal tissue is the tissue that we find largely within the lobules. So it will consist of the acini and the ductal system. These are the acini and the ductal system. They are all found within. So these are lobule, that's a lobule, that's another lobule, that's another lobule. You can see that the lobules are present between the trabeculae of the stromal tissue. This is a higher magnification to demonstrate the parenchyma. It consists of several acini as well as ductal system, but there's something more we can appreciate in this magnification. We can appreciate that we also have a number of adipocytes. They are scattered, so this lightly staining rounded ovoid structures are adipocytes, the fat cells. They are scattered adipocytes within the gland. But the majority of these deeply staining structures are the acini of the gland, and these are the ductal structures of the gland. This image shows you the different types of acini. So we can see that predominantly we have acini which are deeply staining. So these are the ones we call the serous acini, that are the predominant ones in the gland. But we also have some acini which are not deeply staining, they're lightly staining here. So these are mucus acini. They're scattered, very few, usually hardly there. But we also have the adipocytes there, scattered. Before we describe much about the acini and the ductal systems of the parotid gland, let's describe something called the salivon. So the salivon is the basic secretory unit of a salivary gland. It's not limited to parotid. It is a term that we use for the major salivary glands. Each salivon consists of the asinas. The asinus can either be a serous asinus. Serous here would mean that it produces protein-rich secretion. It may also be a mucus acinus, which means it produces a mucin-rich secretion. Or it may be a mixed acini. A mixed acini has both cells which produce protein-rich secretions as well as mucin-rich secretions. So this is standard for salivary glands, not just parotid. The acini can be serous, mucus, or mixed acini. Then draining the acinus is a duct. The duct that directly drains an acinus is called the intercalated duct. From the intercalated ducts, we have what we call striated ducts. These striated ducts, are going to see how they are organized and what makes us to call them striated ducts. And then we have the striated ducts joining to form the excretory ducts, which are also called the extralobular ducts. So the extralobular ducts are the ducts which are outside the lobules. These are the components of the salivon, and this is standard for either parotid, submandibular or sublingual gland. One of the things that is used to distinguish them is the organization of the salivon and especially of the asinas. The type of asinas that are present in the parotid are predominantly serous asinas, the ones which are almost red there, predominantly serous acini. That's one of the things that we use to distinguish parotid gland from the other salivary. Compare that with the acini which you find in the sublingual gland, which are predominantly of mucoid type. The submandibular gland has a mixed type of acini. So this is the salivon, that is the asinas. That's also another asinus. And you see this is now the intercalated ducts. And this intercalated ducts join to form striated ducts, and multiple striated ducts join to form the excretory ducts, which are found at the lobules. So we can also call them the extralobular ducts or interlobar ducts. They're between lobes. With that in mind, now let's talk about the acini that we find within the parotid gland. The acini found within the parotid gland are predominantly serous, as I've already mentioned. And so these are the serous acinas. When you look at each acinus, there's something that is worth noting. Each serous acinus consists of kind of pyramidal cells. They have a wider base and a narrow apex. So the cells are pyramidal kind of, and perhaps a higher multiplication will help us understand that. So this is a serous acinus, for example. The cells have a wider base and a narrow apex. This is the center of the acinus. The cells tend to have on the periphery a lot of rough endoplasmic reticulum, and towards the center a lot of secretory granules. And so that explains why there is differentiation in how the cells stain. The basal sides of the cell stain differently from the apical sides of the cell. So these are the serous acini. But we also have the mucous acini. The mucous acini tend to be, in this case, you can see they appear tubular, kind of. The cells look smaller than the one for serous acini, largely because usually in these preparations, the mucin has already been extracted, and so the cells appear collapsed. But these are the mucous acini, they do not take up stains. All right, how about the ductal system? The ductal system of the parotid gland are of two varieties. We have the ducts which are found within the lobules and the ducts which are found outside the lobules. We can term them intralobular ducts and extralobular ducts. Let's begin with the intralobular ducts, the ducts found within the lobule. So a higher magnification of a lobule will demonstrate some ductal system like this one. That's a duct. That's also a duct. That's a duct. So there are two types of ducts that we find inside the lobules. There are those ducts which are just arising from an acinus. That's the one we call intercalated duct, like this one. That's an intercalated duct. Or that one, that's an intercalated duct. Then we have those ones that we call striated ducts, like this one. That's a striated duct. So histologically, how are they different? An intercalated duct will have cuboidal cells, they are low cuboidal. and they're partly incorporated into the Asinas, as you can see. So that's an intercalated duct. These are the ducts which drain each Asinas. Then the striated ducts are of high cuboidal or simple columnar epithelium, one layer of columnar cuboidal cells. As we can see here, they are definitely larger than the intercalated one. But why do we call them striated ducts? The basal zones of these cells display features of active transportation of ions. And for that reason, there are a lot of arrangement of organelles there that appear like striations. And especially, we have alternating rows of mitochondria and basal membrane enfoldings. And so that makes this region appear striated. We call them striated ducts. Of importance to note is that the striated ducts are surrounded by a rich capillary network, as you can see in that particular region, demonstrating to you how active there is transportation of substances between the ducts and the blood vessels. This still shows you a striated duct, and I've already told you what it entails, but this one is an intercalated duct. As you can see, it's incorporated in the Asinas. Now, how do you distinguish? How do you know that this is actually a duct? Look at the cells. You know, the cells of the ductal system do not have those granules that we see in the cells of the acini. The secretory cells will have secretory granules within them. So they're deeply staining, as you can see. And then the ductal cells are lightly staining. That's how you distinguish them. And that's why you're able to know that that's an intercalated duct. Now we can talk about the extralobular ducts. The extralobular ducts are the larger ducts. We can also call them the excretory ducts, so that the ducts found outside the lobules. The extralobular ducts will tend to have either, depending on its size, simple columnar epithelium or pseudostratified columnar epithelium or stratified cuboidal epithelium on the wall. Of importance to note is that the extralobular ducts are surrounded by a thick connective tissue stroma around it. So they're surrounded by connective tissue. This image shows you one extralobular duct of that nature with stratified cuboidal epithelium and a rich or a thick connective tissue stroma surrounding it. Great. So that is the histology of the parotid gland, and that is the best time now to talk about the parotid duct. Having talked about the histology of the gland and how the ductal system join to form the larger glands, larger ducts, now we can talk about the parotid duct. The parotid duct is also known as the Stenson's duct. It emerges on the anterior border of the gland, slightly on the upper parts rather than on the lower parts. Usually it passes horizontally anterior, and that means that it will be going across the masseter muscle, some centimeters below the zygomatic arc. Now, when it reaches the anterior border of the masseter, it turns medially almost 90 degrees. So it's a sharp turn, almost 90 degrees to go medially. That medial turn of the duct sees to it that it pierces the muscle deep to that one, which is called the buccinator muscle. Before it pierces the buccinator muscle, there's some pad of fat around here that the duct goes through. So it will pass through the buccal fat pad and then pass through the buccinator muscle. This image shows you this green one being the duct. So the 90 degrees turn is made around there. Then it will go through buccal fat pad around there. then go through the buccinator muscle around there. The point at which it pierces the buccinator muscle actually corresponds with the crown of the third maxillary molar tooth. It's the same level, the crown of the third maxillary molar tooth. However, after the duct has gone through the buccinator muscle, before it pierces the oral mucosa, it does something very unique. It runs further anterior between the buccinator muscle and the oral mucosa. It runs obliquely anterior. And then it will pierce now the oral mucosa at the level of the crown of the second maxillary molar. That means that there's some length of the duct between the muscle buccinator and the oral mucosa somewhere there. The importance of this course is to offer a valvular mechanism so that when you have raised intraoral pressure, that pressure is not translated back to the parotid gland to see the parotid gland swell. This is a valve mechanism to prevent backflow, and especially when you have raised intraoral pressure, that pressure is not translated back to inflate the parotid gland. Eventually, the duct opens in the oral mucosa within the vestibule of the mouth. Remember, the vestibule of the mouth is this space between the dental arc and the cheeks. So that's what we call the vestibule of the mouth, between the teeth and the cheeks. That's the vestibule. So it will open in the vestibule on the oral mucosa via a small papilla that will be opposite the second upper molar crown. If you look at the total length of the parotid duct, it's about 5 centimeters long and usually about 3 millimeters wide. Although this duct will be narrower at the point of orifice, but the rest is about 3 millimeters wide. So with that, what are the possible surface landmarks of this particular duct? The traditional way of describing the surface landmark is to take an imaginary line from the philtrum, that's a depression between the nose and the mouth. That midline depression is what we call the philtrum. So you take a point there and a point at the tragus or intertragic notch of the ear there. So you join that with an imaginary line. The parotid duct will fall in the middle third of that imaginary line. So that's a landmark of the parotid duct. We can study the parotid duct radiologically using what we call salography, where a radio-opaque substance is injected through the ampulla of the parotid duct and then pushed through, and then image is acquired. When that happens, we are able to see the outline of the duct. So here, the radiopaque dye has been injected through the ampulla of the parotid duct there. And so we can see the outline of the duct in retrograde. So this shows you the region of the valvular mechanism. Then this shows you the region where it's piercing the buccinator. And this is the region where it's turning from the masseter to turn, the 90 degrees turn we talked about. And when you trace this one posteriorly, you'll see that the duct is formed by union of 2 and sometimes 3 ducts just in front, just before the duct emerges in the anterior border of the parotid gland. So usually there are superior and inferior duct, and sometimes a third one that join to form the parotid duct. When the accessory parotid gland is present, it will also drain into the duct via multiple ducts, about 5 or 6 small ducts draining into the main pancreatic duct, the main parotid duct. All right, now we can talk about the blood supply and lymphatic drainage of the parotid gland. The blood vessels is largely derived from the branches of the external carotid artery. So we have direct branches of the external carotid artery into the gland, but we also have the non-branches, superficial temporal, maxillary artery. So its branches, their branches still supply the parotid gland. In terms of venous drainage, the veins will drain to the external jugular vein via the local tributaries. And you remember that we have direct veins there. The retromandibular vein was also there. So the tributaries drain into them, and most of this blood will go to the external jugular vein. Lymphatic drainage. The lymphatic drainage is by the preauricular nodes, which tend to be the ones which are subcutaneous, and the parotid nodes, which are the glands which are inside the parotid gland itself. Eventually, whether preauricular or the parotid lymph nodes, they all drain to the deep cervical lymph nodes eventually, as we can see in this particular image. All right, so that is the blood supply. Now we can talk about innervation of the parotid gland. Parotid gland receives three types of innervation. We have the secretomotor innervation, the vasomotor innervation, and general sensory innervation. Let's start with the secretomotor innervation. The secretomotor innervation is also termed the parasympathetic innervation. It's the one that targets the parenchymal tissue of the gland, in particular the acini of the gland. And this one stimulates secretion of watery saliva. So because they are parasympathetic, remember that autonomic division of the nervous system consists of, the peripheral elements consist of a preganglionic and a postganglionic neuron. The preganglionic fibers that go to the parotid gland come from a nucleus within the brainstem that we call the inferior salivatory nucleus. Now, remember, a nucleus is a collection of cell bodies of neurons within the central nervous system, especially within the white matter of the CNS. So the cell bodies which eventually innervate parotid gland consist of preganglionic and postganglionic. The preganglionic neurons have their cell bodies inside the brainstem in a nucleus we are calling the inferior salivatory nucleus. This nucleus is a general visceral efferent nucleus. When you talk of general visceral efferent, GVE, it simply means autonomic output. So the inferior salivatory nucleus gives you fibers. The axons from there are the ones which travel within the cranial nerve number 9, which we call the glossopharyngeal nerve. The preganglionic fibers join the glossopharyngeal nerve. Okay, after joining the glossopharyngeal nerve gives rise to a tympanic branch. So that's a branch of the glossopharyngeal nerve that goes to the tympanic plexus. It's called the tympanic nerve, or the tympanic branch. Then from that plexus, the fibers still consolidate now to form what we call the lesser petrosal nerve. From the lesser petrosal nerve. So lesser petrosal nerve is still a branch of the glossopharyngeal nerve, but now from the tympanic plexus. This lesser petrosal nerve is the one that synapses within the otic ganglion. The otic ganglion is deep within a region called the infratemporal fossa. We'll talk about it much later. So that's the end of the preganglionic neurons, the otic ganglion. From the otic ganglion, we have synapsing and postganglionic neurons hitchhike on the auriculotemporal nerve. So they're just hitchhiking. They hitchhike on the auriculotemporal nerve. And it is through that hitchhike that now the postganglionic neurons are able to reach the glandular elements of parotid. So that the secretomotor innervation, the innervation that causes production of watery saliva. Remember, the cranial nerve that supplies that is glossopharyngeal nerve. This image captures for you that as well, from the glossopharyngeal nerve, preganglionic neurons, through the tympanic nerve, then later lesser petossal nerve to the optic ganglion, then postganglionic go to the gland, but now they'll hitchhike on auriculotemporal nerve. Now we can talk about the vasomotor innervation. Vasomotor innervation is a sympathetic innervation. This type of innervation targets the blood vessels, and the aim is to cause vasoconstriction. When it causes vasoconstriction, the end result is production of thick saliva. So it's still production saliva, but the saliva here is slightly thick, mucoid saliva. All right, so how does this work? Similarly, because still autonomic, the preganglionic neurons arise from the spinal cord. Remember that sympathetic outflow is usually thoracolumbar outflow, thoracic and lumbar nerves. So they come from T1 and T2 thoracic nerves, and these preganglionic neurons join the sympathetic chain. Sympathetic chain is extensive, but the ones which now intend to go to the head region will have to climb up a bit, which means that they join the cervical sympathetic chain. The cervical sympathetic chain terminates on its upper end by a ganglion, which we call the superior cervical ganglion. And that is where these preganglionic fibers also synapse at the superior cervical ganglion. Once they've synapse there, we have postganglionic neurons which hitchhike now on blood vessels. The blood vessels that will eventually lead to the parotid gland. So that means that it will follow the external carotid, and then it will follow the various branches of external carotid, similar to the branch that supply the gland. The sympathetic reach the gland through a plexus around blood vessels. The last type of innervation is a genosensory innervation. The genosensory innervation targets the stromal tissue of the gland, either the stroma around, which means the capsule, or the stroma within, which means the trabecular system. This is largely responsible for the genosensations, especially the pain sensations that we know may come from parotid gland. So there are two major nerves responsible for genosensory innervation: the greater auricular nerve that runs on the surface, hence supplying largely the capsule. And we have the auriculotemporal nerve, which runs from deep. So the branches of auriculotemporal nerve largely go to the trabecular system in the gland, and so supplying the connective tissue elements of the gland, within the gland. The auriculotemporal nerve is, in particular, remember, a branch of the posterior division of the mandibular nerve. And mandibular nerve is the third division of the trigeminal nerve. Trigeminal nerve is the fifth cranial nerve. So this shows you the auriculotemporal nerve arising from the mandibular nerve. Mandibular nerve arises from trigeminal. Great, so that summarizes the story of the anatomy of the parotid region. We now want to talk about the anatomy of the facial nerve, and we have four major objectives, but they're short. We'll talk about the nucleus of origin and functional components of the facial nerve. We'll talk about the intracranial course and branch of the facial nerve. We'll also talk about the extracranial course and branch of the facial nerve. And lastly, we'll talk about something on applied anatomy. Let's begin with the nucleus of origin and their functional components. So as I've already mentioned to you, a nucleus is an aggregation of cell bodies of neurons inside the white matter of the central nervous system. So this, we have in the brainstem what we call cranial nerve nuclei. which means a nuclei related to the giving rise of cranial nerves. We want to look at the nuclei related to facial nerve. These nuclei are largely located around the pons and medulla oblongata. One of the major nucleus related to facial nerve is what we call the motor nucleus of facial. The motor nucleus of facial is a special visceral efferent nucleus. And when we say something has a special visceral efferent function, it simply means that it supplies muscles of pharyngeal arc origin. So we can also say it's a branchiomotor nucleus or a pharyngeomotor nucleus. It's a nucleus responsible for giving rise to nerves that supply pharyngeal musculature, pharyngeal arc musculature. In particular, facial nerve supplies muscle of the second pharyngeal arc. And so the neurons which go to those musculature come from the motor nucleus of facial. We also have what we call the superior salivatory nucleus. The superior salivatory nucleus is a general visceral efferent nucleus. GVE simply means that it is giving us to an autonomic outflow. Now for cranial nerves, this GVE will be parasympathetic outflow. So superior salivatory nucleus gives rise to parasympathetic outflow that goes to the salivary glands. In particular, we have the submandibular and sublingual salivary glands. Those are the major ones, but there are other minor ones. Then you have the lacrimatory nucleus. Lacrimatory nucleus can be considered part of the superior salivatory nucleus, the upper part of it actually. You can consider it to be different. Lacrimatory nucleus is therefore still GVE, which means parasympathetic, to the lacrimal gland. This is the one that offers secretomotor function to the lacrimal gland, just like superior salivatory offers the secretomotor function to submandibular and sublingual gland. We have the nucleus of the solitary tract, otherwise known as nucleus of the tractus solitarius. Now, nucleus of the solitary tract is a very big nucleus. The upper part of it is termed the gustatory nucleus. This gustatory nucleus is related to the function of taste. So basically, this is the point of termination of neurons responsible for carrying taste sensation from the tongue. Now, facial nerve, being one of the nerves that conveys taste sensation, is related therefore to the gustatory nucleus. The gustatory nucleus is considered a special visceral afferent nucleus, and that simply means, in this particular context, taste sensation. That does not mean that the whole of the nucleus tractus solitarius is an SVA nucleus, not quite. Some parts of the nucleus of the solitary tract is actually GVA, general visceral afferent, which means autonomic afferents, and those ones are related to glossopharyngeal and vagus nerve from baroreceptors and chemoreceptors around blood vessels. Then we have the nucleus, the spinal nucleus of trigeminal nerve. The spinal nucleus of trigeminal nerve is a general somatic afferent nucleus. And general somatic afferent here simply means general sensations. Things like pain, temperature, touch, pressure, and the like. That's GSA function. So in simple terms, facial nerve also carries some GSA function, general sensory function. And we're going to see from where, in particular, they come from somewhere around the ear. So there are 5 nuclei related to facial nerve according to their different functional components. This nuclei, in this image, you can see the many nuclei there. The lacrimatory nucleus related to innervation of the lacrimal gland. We have the superior salivatory nucleus related to innervation of the Salivary gland, remember that is parasympathetic, so you'll have preganglionic and postganglionic fibers, just like this one is parasympathetic. So there will be preganglionic and postganglionic fibers and a ganglion somewhere. Then there is the motor nucleus of 7 or facial. That one is the one that targets muscles of facial expression. We can also see the nucleus tractus solitarius. The upper part of it is what we call the gustatory nucleus. And this is the one coming from the anterior 2/3 of the tongue, as you can see there. And lastly, we have the nucleus, the spinal nucleus of trigeminal, and especially this lower part of it. So the fibers from there, or the fibers that terminate there, come from the ear. It's an afferent nucleus. This other image shows you the various nucleofacial that join to form 2 major components of the facial nerve. This one, which we call the main facial nerve or facial nerve proper, and this one, which we call the nervus intermedius. In particular, I want you to see that the facial nerve proper is the one that is arising from the motor nucleus of facial. So that's the one with SVE function. Then the other functions of facial nerve, the fibers mediating the other functions of facial nerve are carried through what we call the nervus intermedius. Now we can talk about the intracranial course and branches of facial nerve. So facial nerve emerges at the cerebropontine angle via 2 routes, as I've just mentioned. We have what we call the facial nerve proper, and this is the branchiomotor route. Is the pharyngeomotor route, the route that carries nerves that supply muscles of facial expression. And we have the nervus intermedius route. The nervus intermedius route carry the parasympathetic, or we can call them secretomotor functions, and the sensory functions. The sensory here can either be general and special. Remember, the special is for taste. This image shows you the cerebropontine angle there. This is facial nerve proper, and that tiny one is the nervus intermedius. So the 2 constitute facial nerve at the cerebropontine angle. We can describe the intracranial course of the facial nerve in multiple segments. So we can have what we call the pontine segment, the meatus segment, the labyrinthine segment, tympanic segment, and the muscle segment. I've called it 4 here if we eliminate the pontine segment. So the others would be 4. Once it enters the skull, there are 4 segments. But before it enters the skull, you can call that part the cranial or the pontine segment, or the intracranial, the intercavital segment. So you can just call the cranial segment. So here, there's that part from pons to bone of the skull, the cranial segment. Then the part that passes through the skull, we have the meatus segment, labyrinthine segment, tympanic segment, and mustard segment until it comes out. So let's describe those 4 or 5 segments of the facial nerve. Let's begin the pontine segment. This is the segment from the brainstem before the facial nerve enters the internal auditory meatus. So that tells you that the facial nerve usually goes through the internal auditory meatus. Both routes, which means that the facial nerve proper and the nervus intermedius component come out as separate entities at the cerebropontine angle. Remember, the cerebropontine angle is actually the junction also between the pons and the medulla, so we can call the the pontomedullary junction. They're not necessarily the same concept, but that's where the facial nerve comes from. Facial nerve does not come out there alone. It comes out in company of the vestibulocochlear nerve as well. That's the cranial nerve number 8. So here, this is facial nerve number 7. and this is vestibulocochlear, number 8. This is the cerebellopontine angle between cerebellum and pons, but this is still pontomedullary junction between pons and medulla, that region. So they're not necessarily the same concept, but around the same area, yes. Both the facial nerve and the vestibulocochlear nerve pass through a cistern within here. A cistern is an enlarged subarachnoid space. Subarachnoid spaces contain cerebrospinal fluid. So an enlarged subarachnoid space is called a cistern. The cistern that is found here is called the cistern of the cerebellopontine angle. So the nerves pass through that cistern and then usually enter the internal auditory meatus. As they pass through that cistern, the nervous intermediate component is in between facial nerve proper and the vestibulocochlear nerve, as we can see in that particular image. So the three nerves, facial nerve proper, nervus intermedius, and vestibulocochlear, exit the cranial cavity by going through porus acousticus. Porus acousticus is the medial opening of the internal auditory meatus. It's the medial opening of the internal auditory meatus. So the three nerves enter through that, but they also enter together with another vessel, the labyrinthine artery. This is the artery that comes from the vertebrobasilar system, going to supply the structures in the inner ear. This image shows you the opening of the internal auditory meatus there, so that the porus acousticus. The porus acousticus will tend to be slightly wider than the actual tunnel of the canal. But yes, it's the medial opening. Okay, once the nerve has entered through porus acousticus, it will now be within the internal auditory meatus. And that is why we call this one the meatal segment. So the meatal segment of the facial nerve refers to the part of the facial nerve that goes through the internal auditory meatus. Remember, it's not the only nerve that goes through there. So the neural elements that go through the internal auditory meatus tend to occupy specific compartments of the meatus, and especially as they move towards the lateral aspect of the canal, towards the ear, the neural elements tend to occupy some specific compartments of the canal. At this point, the nervus intermedius has already united with the facial nerve proper, and so it's just one big thing. The compartments occupied by these neurons are like this. We divide the internal auditory meatus into 4 quadrants. So there's the anterior superior aspect. That's the one occupied by the facial nerve, both proper as well as nervus intermedius. You can just call that one the facial nerve proper. So that one occupies the anterior superior aspect of the canal. Remember that the vestibulocochlear nerve consists of cochlear and vestibular nerve. The cochlear nerve occupies the anterior inferior aspect of the canal. The vestibular nerve has 2 divisions, the superior and the inferior divisions. The superior division occupies the posterior superior aspect of the canal, and the inferior division occupies the posterior inferior division of the canal. Usually there's a transverse crest of bone that separates the superior from the inferior parts, compartments. And then there's also another crest of bone, which we call the Bill's bar, that separate the superior components into anterior and posterior. Perhaps you can see it here. So facial nerve occupies the anterior superior aspect of the canal. That's the Bill's crest or Bill's bar. Then this is the horizontal crest or the falciform crest. separating the superior vestibular nerve and the inferior vestibular nerve. This is the cochlear nerve. So once the facial nerve has passed through the anterior superior aspect of the canal, as you go towards the lateral aspect of the canal, towards the end of the canal, what we call now the fundus of the canal, the facial nerve exits through a canal. So this image still shows you the Bill's-Bar there, the falciform or the transverse crest. So this is where we expect facial nerve to be. This is where we expect the superior vestibular nerve to be. This is the inferior vestibular nerve, and this is the cochlear nerve region. Facial nerve exits. So this is the end of the internal acoustic meatus, the most lateral aspect of it. We see facial nerve exiting through that canal, which is in the anterior superior aspect of the internal auditory meatus. That canal is called the facial canal. When it exits there, it goes to the third segment, which we call the labyrinthine segment. So the labyrinthine segment refers to the segment after the internal acoustic meatus, that the segment that goes through the facial canal. Usually it will be very short and it immediately ends in a bend, a very sharp bend. We call the first genu of the facial nerve. And that point of bend is where we find the geniculate ganglion. So the labyrinthine segment of facial nerve houses the geniculate ganglion of facial nerve. Remember, a ganglion is a collection of cell bodies of neurons outside the central nervous system in this particular context. So this is the facial nerve coming in. That's the labyrinthine segment. Then it ends into the facial ganglion, what we call the geniculate ganglion. Take note of the following. 1, the geniculate ganglion houses the cell bodies of the sensory nerve fibers of facial nerve. So the ones which carry taste, the neurons that carry taste from the tongue, their cell bodies are housed here. So the peripheral processes are the ones which will be going to the tongue. The central processes now go to the brainstem. Their cell bodies are housed within the geniculate ganglion. Also, the ones which carry general sensation around the ear, their cell bodies are also housed here. So geniculate ganglion houses cell bodies of the sensory nerves related to facial nerve. We have a nerve that arises from the labyrinthine segment, actually at the apex of the geniculate ganglion. We call that nerve the greater petrosal nerve. The greater petrosal nerve is given off at the level of the geniculate ganglion, which means given off at the labyrinthine segment of the facial nerve. This is the greater petrosal nerve, as you can see it there. So this greater petrosal nerve is an important branch of facial nerve because it carries 2 functional components. It carries the preganglionic parasympathetic fibers of facial nerve that target the glands above the mouth. So which are these glands above the mouth? The lacrimal gland and the salivary glands located around the nasal, the salivary glands in the palate, the palatal glands. So it targets them. It also targets the glands around the nose anyway. It is parasympathetic to these glands. Now remember, they are preganglionic fibers, so they must synapse somewhere. The synapse at the what we call the pterygopalatal ganglion, also known as the sphenopalatine ganglion. Postganglionic fibers from the pterygopalatal ganglion are the ones which go to the lacrimal gland and also to the palatal glands. They will have to hitchhike on other nerves to reach wherever they're going. Other than carrying preganglionic fibers, the greater petrosal nerve also has some taste fibers. The taste fibers of facial which run through this nerve are targeting the taste buds around the palate. So remember the upper part. All right, so that is it about the greater petrosal nerve. Look at this one. So this is the facial nerve giving you the greater petrosal nerve there. This greater petrosal nerve goes all the way to the pterygopalatine ganglion. Now, some important anatomy about greater petrosal nerve that you need to understand is this. That greater petrosal nerve given off by the facial nerve is joined by another nerve, which we call the deep petrosal nerve. Deep petrosal nerve is a sympathetic nerve plexus. So there are postganglionic sympathetic nerve plexus that were around the internal carotid artery. Remember, I mentioned to you earlier that postganglionic sympathetics may hitchhike on blood vessels. So the one that hitchhike on the internal carotid join to form the deep petrosal nerve. Deep petrosal nerve join with the greater petrosal nerve somewhere, and they form a common nerve, which we call nerve of the pterygoid canal. The nerve passes through pterygoid canal, so we call it nerve of the pterygoid canal. So that nerve of the pterygoid canal is also known as the Vidian nerve. Pterygoid canal is also called the Vidian canal. So the Vidian nerve terminates in the pterygopalatine ganglion, yes, but only the parasympathetic fibers are synapsing there. Remember, the sympathetics are already postganglionic, so they do not synapse there, they just pass. And then from there, the postganglionics, we go to different destinations depending on the target. Those ones which go to lacrimal gland, we love to hitchhike on the lacrimal nerve, which is a branch of the ophthalmic nerve. The ones which target the palate, we love to go to the nerves which go to the palate. All right, so that is the labyrinthine segment. Remember, one major branch from the labyrinthine segment, the greater petrosal nerve, and I've given you the distribution. This also shows you the greater petrosal nerve, the facial nerve, but now let's follow the one that eventually is in the greater petrosal nerve. There are preganglionic parasympathetic fibers, so they're the ones which eventually started from the superior salivatory nucleus, as well as lacrimatory nucleus. They pass through, so they don't synapse in the genital ganglion per se, they just pass, and then will synapse at the pterygopalatine ganglion, from where we have postganglionic fibers which go either to the nasal glands, the palatine glands, and also the lacrimal gland. After the labyrinthine segment, we go to the tympanic segment. This is the tympanic segment of the facial nerve. The tympanic segment of the facial nerve is a part of the facial nerve that passes on the medial wall of the tympanic cavity. So it's a segment from the geniculate ganglion, basically, but the nerve runs posteriorly and horizontally, usually just below the impression of the lateral semicircular canal, which is that one. Or this particular one. So this is the segment we're talking about, the tympanic part. It's on the medial wall of the tympanic cavity. Don't confuse that one, the tympanic membrane. Remember, tympanic membrane is the lateral wall of the tympanic cavity. There are no branches that are given from this particular segment of the facial nerve, so no big deal. This segment ends on a second bend, not as sharp as the first one, but that's the second genu of the facial nerve. That second genu of the facial nerve sees to it that now the nerve turns from being horizontal to now being vertical, in what will take us to the last segment of the intracranial facial nerve. And that last segment is the mastoid segment, also known as the vertical segment. So this is a vertical segment after the second genu. The vertical segment of the facial nerve refers to the part of the facial nerve that passes through the stylomastoid canal, which is found within the temporal bone, going vertically. The vertical segment, which is the muscle segment of the facial nerve, will end through the stylomastoid foramen, and that is where the facial nerve exits as it ends its intracranial route to become extracranial. There are three branches which are given from this vertical segment of the facial nerve. We have nerve to stapedius muscle. That the stapedius muscle, the muscle that anchors stapes. Remember, stapes is one of the ear ossicles. So the muscle that anchors is called stapedius, and the nerve that supplies that muscle is called nerve to stapedius. Stapedius is also one of the muscles of the second pharyngeal arc, and that is why it's innervated by the facial nerve. We have a sensory branch which goes to the ear. We call the sensory auricular branch. This sensory auricular branch joins the auricular branch of the vagus nerve. Vagus nerve is the 10th cranial nerve, and they contribute to innervation of the outer ear. In particular, they contribute to innervation of the auditory canal, the external auditory meatus, some parts, also some part of the auricle and the skin behind the auricle. So this is the 10th cranial nerve, which is called vagus, and this is the 7th nerve, which is called facial. So this is the auricular branch of vagus, and this is the auricular branch, the sensory auricular branch of facial that joins the auricular branch of vagus. They are responsible for general sensory innervation around the regions I've mentioned in the ear. And so these fibers, their nucleus is the one related to the spinal nucleus of trigeminal. It's a GSA nucleus. The largest nerve given in this region is what we call the coda tympani nerve. The coda tympani nerve is given from the vertical segment of the facial nerve, and it runs anteriorly, usually next now to the tympanic membrane itself, and that's why it's called the tympanic cord. It eventually runs to join the lingual nerve. Lingual nerve is a branch of the mandibular nerve, and the mandibular branch is a branch of the trigeminal nerve. So this lingual nerve is a branch of the mandibular nerve that goes to the tongue. Coda tympani joins the lingual nerve. What does coda tympani has? Perhaps this image shows us better the anatomy of the coda tympani. So this is the facial nerve, the vertical segment, giving us nerve to stapedius, and now coda tympani here, which passes now through the middle ear again, but now next to the tympanic membrane. So that's what's called the tympanic cord. Comes out through a particular fissure, then joins the lingual nerve, which is a branch of the mandibular nerve, which is a branch of the trigeminal nerve. So this coda tympani nerve carries some functions. Two of them. It has the preganglionic parasympathetic fibers, which go to synapse in the submandibular ganglion. From the submandibular ganglion, the postganglionic fibers go to supply the sublingual, submandibular, and the lingual salivary glands. So sublingual and submandibular, those are the large salivary glands, but we also have minor salivary glands within the tongue, still supplied by these nerves. It is parasympathetic to those. So that offers secretomotor function. Remember, the synapsing is at the submandibular ganglion. Well, coda tympani also carry the taste fibers, the fibers responsible for taste sensation from the anterior 2/3 of the tongue. So this is the tongue. The anterior 2/3 of the tongue has the taste sensory fibers, which join lingual nerve, but then coda tympani, eventually facial nerve. Their cell bodies are located within the geniculate ganglion. Then the central process go all the way to the gustatory nucleus or the nucleus of the solitary tract. For the preganglionics, parasympathetic, remember we'll trace that from the superior salivatory nucleus. So we have the preganglionic fibers coming, joining chorda tympani, then joining lingual, then synapsing within the submandibular ganglion. Then from here, postganglionic fibers go to the sublingual and submandibular gland, still through lingual nerve actually. And I've told you that there are also other glands which are within the tongue, the lingual salivary glands, which are still supplied by these nerves. So chorda tympani has a secretomotor function as well as taste function. Now we can talk about the extracranial branches of the extracranial course and branch of the facial nerve, having talked about the intracranial course and branches. The extracranial course of facial nerve is not that complex, it's straightforward. The facial nerve emerges from the base of skull through the stylomastoid foramen. Immediately it comes out, the nerve gives rise to some nerves before it enters the parotid gland. One of them is the muscular branch that goes to the posterior belly of the gastric muscle. And that could possibly tell you that that muscle is of second pharyngeal arc origin as well. It also gives you a branch that goes to the stylohyoid muscle, telling you that that muscle is also from second pharyngeal arc. And then it gives you the posterior auricular nerve. This is the posterior auricular nerve. Now, posterior auricular nerve may target multiple things. This is the posterior auricular nerve that's given off by facial nerve. It may supply the muscles related to the auricula, so the auricularis superior and auricularis posterior, but also supplies the occipital belly of the occipitofrontalis muscle, or what you call epicranius. That's the distribution of the posterior auricular nerve. After the facial nerve has given rise to those branches, facial nerve enters the substance of the parotid gland, usually from the posteromedial surface of the gland. So this is facial nerve. This is the posterior auricular branch of facial going behind there. And perhaps that's a motor branch of posterior belly of the gastric. And this is facial nerve now within parotid, although parotid has been removed so that you can see the nerve nicely. Okay, now within the parotid gland, the nerve divides into two major trunks. We have the temporofacial trunk, which is the superior one, this one, and the cervicofacial trunk, which is the inferior one, this one. These two trunks further divide into other branches, so kind of forming a plexus. We can see a plexus there, we can see a plexus here. And as a matter of fact, sometimes these ones also reunite to form even extensive plexus. And so the plexus formed by the facial nerve branches within the parotid gland looks like the foot of a duck, and that's why it's called the pes and serina. You can see how extensive that plexus is. From this plexus, there are many patterns of the plexus. From the plexuses, there are 5 main terminal branches of facial nerve that have been described. We have temporal branch, which are the most superior there, so going to that territory. We have zygomatic branches, which tend to be multiple around the zygomatic region. We have the buccal branch, which is in most cases just one, but could divide into multiple. We have the marginal mandibular branch, which tends to be 2 most of the time, marginal mandibular branches. And you have the cervical branch, which in most cases just 1, going all the way to the platysma. So these terminal branches of facial nerves supply the muscles of facial expression. Of course, now you can take it upon yourself to then figure out, so which terminal branch of facial will supply which group of muscles of facial expression. Definitely don't expect the cervical branch to be the one supplying orbicularis oculi, for example. Neither should you expect the temporal branch to be the one supplying platysma or the muscles around the oral cavity. So basically, they just follow the concept of the territory. As a concept, remember the terminal branches supply the muscles of facial expression. That brings me to the final task of just talking about clinical anatomy of facial nerve. And this will be more of triggering your mind rather than saying much. But before that, let me mention something about what we call upper motor neuron lesion of facial nerve and lower motor neuron lesion of facial nerve. So facial nerve comes from its nucleus within the brainstem, and here we're looking at the motor nucleus of facial. The axons of neuron whose cell bodies are within the motor nucleus of facial are the ones which constitute facial nerve, and those are the lower motor neurons. So they come from the brainstem. Their cell bodies on the brainstem, their axons come out to supply the muscles of facial expression. So the right one will supply the right hemiface, and the left one will supply the left hemiface. This nucleus is controlled from higher centers, and in this case, from the cerebral cortex. So the neuron that comes from the cerebral cortex to go to the facial nerve nucleus is the one we call the upper motor neuron, because it comes from the cortex to a brainstem region. We can call it corticobulbar or corticonuclear. Now, the distinction is this. Regarding the upper face, the facial nerve nucleus that controls the portion of the nucleus that controls the muscles of the upper face are controlled or are regulated from both hemispheres. In simple terms, they receive what we call bilateral projection. So for example, if you look at the muscles on this upper side, the neurons which go to the muscles of the upper part receive from both sides. They receive bilateral projection from the corticobulbar tract. However, the muscles which are on the lower part of the face do not receive bilateral projection, but they receive unilateral, or rather, let me use the term contralateral projection. It's one-sided projection and it's contralateral. Let's use this blue to help us understand the concept. So this one is an upper motor neuron from the right cerebral cortex. It projects bilaterally, yes. But the bilateral projection we're getting here, the bilateral one here targets the upper face, and then the contralateral here will target the lower face of the opposite side. That means what? That the upper part of the face, the musculature of the upper part of the face, are controlled from both the right and the left cerebral cortex. But the muscles on the lower half of the face are controlled from only the opposite cerebral cortex, as with regard to the origin of the corticobulbar pathway, which projects the facial nerve nucleus. So what are the implications? The implication is this. If you have an upper motor neuron lesion of facial nerve, you are likely to have clinical manifestation that only manifest in the lower part of the face. but the upper part of the face is spared. The assumption here is that that injury has affected only one side. So because the upper face received from both right and left, if you injure only the right side, the left projection will still protect the upper face. But if you injure the right side only, the lower face will be affected because the left lower face relies wholly on that right projection. So the lower opposite side will be affected, but the upper part is not affected. So upper motor neuron lesions of facial nerve manifest with lower face manifestation, but they spare the upper face. And how we know that it spares the upper face, you can look at the wrinkling of the frontalis muscle there. If it's intact bilaterally, then you know that the upper face is not affected, but the lower face is affected. And how is the lower face affected? The lower face is affected in that the muscles of facial expression, the lower part, are paralyzed on one side. So think about it. If you paralyze the muscles on the left side, it means that these muscles cannot pull. They are paralyzed. So what happens? The mouth will be pulled by the side that is functioning. So if this left side is paralyzed, this right side is okay. This muscle, the right, will pull. And so my mouth will deviate to the right. What we are saying is this, that if the lower face, if the face is paralyzed, the side that is paralyzed will not function. The opposite side will then pull the mouth. So the mouth usually deviates away from the paralyzed side of the face. But remember, if this is an upper motor neuron lesion, then this paralyzed side of the face was being controlled by the opposite side of the cerebral cortex. So it could actually be that the side that the mouth is going is the same side where the injury is in the cerebral cortex. Now think about then a lower motor neuron lesion of facial. A lower motor neuron lesion of facial nerve affects the facial nerve after the nucleus. So we usually call them infranuclear lesions to distinguish them from supranuclear lesions, which are upper motor neuron lesions. An infranuclear lesion of facial nerve will affect the whole of the hemiface because one side of the face relies wholly on that facial nerve. So infranuclear lesions do not spare the upper face. It affects the whole of the upper face. Supranuclear lesions spare the upper face. And that's the take-home message I want you to get. The reason is because the upper face is spared because the upper face has bilateral projection. So it's protected when you affect one side of the upper motor neuron. But lower motor neuron is no alternative. The right facial nerve supplies the whole half of the right side. So the whole half will be affected. And common terminologies that we have for lower motor neuron lesions of facial, there are multiple, but the commonest conditions, what we call Bell's palsy, which is due to perhaps inflammation, due to neural viral neuritis of the facial nerve within the ear. And so there could be multiple clinical manifestations. Now, on this second image, I want you to just exercise your mind a bit. Think about how facial nerve runs in those multiple segments you talked about. Also think about the different functions of facial nerve that it has. And then think about if you were to injure facial nerve at different parts. Part A, just before the stylomastoid foramen. After it has given all the branches apart from, of course, the terminal motor branches there. Or part B, before it gives rise to the chorda tympani. Or part C, before it gives rise to even the muscle, to the nerve to stapedius. Or part D, even before it gives rise to any branch, including the greater petrosal. What would be the difference in clinical presentation for those different parts that are affected? So that's the thought for you. You need to just work it out, and remember, it's just dependent on what is involved. Remember, part D will affect everything, but part A will spare most of the things apart from the muscles of facial expression. All right, with that, I think I can close it there. So that is the end of this particular session. We've looked at parotid region. We've also looked at anatomy of the facial nerve, very detailed, but you've learned it. Our next series of lectures on head and neck anatomy will be very simple, though. It will focus on the anatomy of the orbit and the eyeball. I don't think it will be very simple, but very interesting. All right, thank you very much.